Good afternoon, everybody. Thank you, Dr. Raju and the MCS team for this wonderful opportunity. My case is a divergent fracture dislocation of the shoulders. So, shoulder dislocation is one of the commonest injuries in the shoulder, or 96% are anterior, 2 to 3% are posterior. Incidence of fracture is about 0.3% in dislocation and has been classified by Neer, Evo and Much. Bilateral dislocations are rare and seen in epileptics, electric shock, sports injuries and electroconvulsive therapy. They are mostly posterior. And bilateral dislocations are less common. Fractures with dislocation is even rare. Divergent dislocation, which is one side anterior and one side posterior, is even more rare. And divergent dislocation with bilateral greater tuberosity fracture has not been reported. Just one has been reported. We'll come into the details. We reported this in the Journal of Case Reports. So this is my patient, 35-year-old temple priest with a known history of epilepsy, dislocated his shoulders during a generalized seizure episode. The left arm, when he was having the seizure, got stuck between the wall and a cupboard, and the right arm was free. And this was the radiograph of the right shoulder. You can see a split type of fracture of the greater tuberosity, and this is the left shoulder, the depression type of fracture. Before we do ARS, I would like to open a couple of questions. Would anyone do other investigations, CT scan for this patient, or an MRI, and the reasons?
CT scan.
Okay. I did not perform CT. The literature says the indication for CT is usually an adult more than 50 years, and to rule out occult, basically for occult humeral neck fractures. And the MRI is also not recommended as a routine practice. They recommend MRI if there's persistent pain, stiffness, weakness, or instability after 3 months. So I proceeded with this. So can we have the first question, please? So what would you do for this case?
Very few of them answer. I think the ARS is not. ARS is not. 4 and 6 are the same.
Oh, sorry. That's probably why. I preferred close reduction under general anesthesia for the dislocation and assessment for fracture reduction and fixation. So, MUA was done under light anesthesia. So the close reduction under sedation and analgesia or lighter anesthesia is not preferred because it could cause a fracture neck of the humerus. Some cases may be associated with an occult fracture neck of humerus, and they could displace. So I went for a reduction under GA.
Can we have the presentation?
Can we have the next question, please? And what would you do for the fracture? What is your preference for the fracture?
Post-reduction.
I think it's not showing. So let. We'll do it again.
Can we have the post-op, post-reduction X-rays before we answer this?
Sorry, this I actually, this was done under image intensifier. The reduction was not satisfactory on both sides, so I had to choose fixation. So
Okay, so the reduction was tried under anesthesia?
the GA, under
G-
general anesthesia, I did a close reduction,
Okay,
and the fracture reduction was not satisfactory, it was displaced. So I had to proceed with the fixation of the fracture.
okay,
Both sides.
okay.
So I was giving the options for fixation in the second question actually.
Okay. So can we have the X-rays of the post-reduction?
We don't have the X-ray.
Patient is still on table actually.
Yes.
And this was in the first sitting only. You had a failed attempt on reduction, and immediately you proceeded
No.
for the open one.
No, I think, no, what
The
he's trying to say
patient
is
still on table.
the joint is congruent, but the fracture fragments are
They
not
were
in
not
position. So what Sri is asking is, how would
How
you
would
then
you fix
address
the
the
fracture?
fracture?
Okay.
What would be your option for fixing fractures? And that was the second question actually. If the error is one-
I would have just asked, how many of us would have fixed on the same? Or after reduction, doing a CT scan, identifying what are the sizes of the fragment, so the strategy of fixing the fragment, and then do it later dates.
And what would be the option for fixing the fracture? So I went ahead with the suture fixation because I've performed these before, achieved satisfactory results, and some evidence for suture bridge fixation being superior.
Can we go back on the presentation? The slides are not coming. Yes.
So this is after fixing.
Sri, can I just stop you here for a second? I think Amit's raising a point here. So if you are doing it in daylight hours and you are a capable shoulder surgeon, would you come out and wake the patient from an anesthetic and get a CT scan, or would you like to go and fix the fractures, the tuberosity fractures at the same sitting? I think that's the question that you've asked, and that's the point which Amit is raising. So just a show of hands of how many people will wake this patient up, take them for a CT scan, and then plan fixation of the tuberosities. So there are some of us who won't do it, and you proceeded to do it at the same sitting?
Yeah, patient was under the general anesthesia, so I proceeded to fix it in the same sitting because the fracture reduction was not satisfactory under the image. So this is actually a week after the fixing. The left is still, the left had actually displaced. So while the right tuberosity remained stable, the left side had displaced. So I took him back to theatre and fixed the left side, this time with a suture and screw fixation. The fragment had actually split into two, and I passed the suture this time at the tendon, the bone tendon junction going through the tendon. And these are the operative and immediate post-operative images. Resuturing was done under anesthesia, and the fixation was reinforced with 4 millimeter cannulated cancellous screws. Greater tuberosity fracture, as I said, was split into two. We had advised a sling for both shoulders, and pendulum exercises started 2 weeks post-operatively, followed by active assisted and active exercises. Fracture had united at 8 weeks on the right shoulder and 12 weeks on the left side. And these are the videos at final follow at 6 years. He had a few episodes of incomplete seizures, 1 or 2 complete seizures, but no episode of further dislocation of the shoulder or any complaints with his shoulder. This is a forward flexion.
So great result, Sri, but why did the left one fixation fail in the first instance? How did you fixed it?
I think the reason I felt was it was a single fragment initially. took the bite of the suture through the bone. I must have taken it with the tendon in the first instance itself. Epileptic patients are on phenytoin, and this can cause osteoporosis. I think we should keep that in mind when we fix these patients, because they can easily cut through the sutures, or the fixation device can easily cut through the bone and can fail.
Is that called the dislocation push-up that which this guy was doing?
So he had demonstrated push-ups.
I think that's a very valid point about using suture fixation, that your suture bite should be through the tendon rather than the bone. The bone's very fragile. There's usually just a shell of bone, so treat it like a big cuff it and put the shield fragment and do a crisscross double row repair rather than using screws or putting sutures through the bone. I think that's what my experience is. I don't know if there's anyone who would add any further comment.
I just wanted to ask one thing, whether you would, in a case of dislocation which has been reduced effectively and there is a GT fracture which is displaced, do you address the dislocation also at the same setting when you are operating, or you just leave it for next time?
I'll come to that in the discussion part actually. Can I just ask one more question to the open forum? How many of you would investigate for osteoporosis in such a patient epileptic with anti-epileptics for maybe 5 years, 10 years? Would you like to check for osteoporosis, and how do you plan your fixation?
So, so the tuberosities are usually osteoporotic, and as mentioned, the screws usually they don't hold well, and it really flies off if you just put screws. So it's always better to use suture fixation. Maybe for the lateral row you can use screws, but you have to use some sort of suture fixation for these devices, and those sutures should pass through the musculotendinous junction.
Yeah, I've started using tapes now. So I use kind of a speed bridge construct, just treat them as a double row cuff repair and pass tapes. So middle row anchors with tapes, and then make a sort of a tension band with the tape, and then get lateral row anchors. I think that's the key. The thing is that you're not going to use any metal work, and you're not relying on bony fixation, so you're just treating it as a soft tissue fixation.
These are especially the left side, these are the cases which I put a couple of screws initially, and then just figure eight using the tape.
Isn't it a good idea to use a small plate instead of putting those canceller screws, because the bone hold is not so strong? So
Yeah,
plate will secure the entire construct, and we can mobilize it early.
So just a caution with the plate. So there is a special, we use the Smith & Nephew system, and there is a greater tuberosity plate which has got claws on it, which sort of pulls the tuberosity down. But it has got one screw distally which goes through just the metaphyseal diaphyseal junction, and that can act as a stress riser. I've done a patient recently who I fixed the GT, did very well. Back playing golf, fell on the golf course, and she's fractured just through my inferior screw hole just below the plate. So that's a little bit of an issue there.
But these
Yes,
plates
sir.
usually have holes to tie up your tendon.
Yeah, so and
Yes.
these have got tines in them, so they grip the tuberosity and bring it down.
In very severe osteoporotic bones, I did a case recently, even the sutures were cutting off like cheese. So in those cases, they recommend using a proximal humeral plate and tie your sutures to the plate so that the reduction stays. Coming on to this discussion, majority of these are anterior dislocations. The bilateral ones are mostly posterior. Incidence of fracture, as we have seen, and the mechanism of posterior dislocation is adduction, axial loading, flexion, and internal rotation. Whereas for the anterior dislocation is abduction, extension, external rotation. And for the fractures, the mechanism of fractures include violent contractures of muscles, impingement over glenoid or acromion, or due to weakness of bone or direct trauma. The GT fracture dislocations are different from isolated GT fractures, and there's greater soft tissue injury, capsulolabral injuries, biceps injuries, and rotator cuff injuries. And also there's a mismatch between the fracture and its bed. And the bed is not very stable because of the instability. So some authors actually recommend fixing all the fractures even if they appear reduced post-reduction. So, and these have been classified by Much into 3 types: avulsion, split and depression. As we can see here, with dislocation, there's 46% of these are depressed, whereas if you include those without dislocation, the depression types are the least. In fracture dislocations, the recommendations include AP view in external rotation to see clearly, axillary and scapular Y views. No CT or MRI is routinely recommended. The GT ratio and impingement index may help deciding the surgery depending on how much the fragment has displaced. And MRI indications include persistent symptoms at 3 months. Routine capsulolabral fixation is also not recommended because they tend to cause stiffness in these patients. So fixing the GT fragment alone appears to be enough for these cases. Some of these cases have occult humeral head fracture, and almost 1/3 have iatrogenic humeral neck fracture at reduction. So CT scan is recommended more than 50 years of age, where osteoporosis is expected. Reduction is preferable under GA to reduce the incidence of fractures, and these fractures are unstable even after reduction, with 51% of them having a secondary displacement. And Bankart repair is recommended if more than 15% of glenoid rim is fractured. Fixation is recommended for more than 5 millimeters of displacement in the normal population and more than 3 millimeters in the athletes in the isolated GT fractures. But in GT fracture dislocations, even anatomical reduction is at risk of displacement. So some surgeons either fix it initially or they follow these patients closely for displacement. And we proposed a classification of bilateral, for the bilateral dislocations as simultaneous and sequential. Sequential is one after the other shoulder dislocating. Simultaneous is when both the shoulders dislocating at the same time. Our case was a sequential dislocation. He dislocated one shoulder before he fell down and dislocated the other. So there were 11 reports of divergent fracture dislocation in the literature, including our publication at the time of our publication, and there's no more reported after that actually. And we attempted to classify and found 5 simultaneous and 6 sequential dislocations. 10 cases were reported after the year 2000. 9 were male, 1 female, 1 the sex was not given. 8 were related to seizures and convulsions. So majority of these occur with seizures.
And Dr. Srinivas, can we just rush through yours?
Oh, yeah. So to summarize, these are not the same as isolated GT fractures. They are inherently more unstable and compared to the isolated GT fractures. Fractures and soft tissue issues to be kept in mind while evaluating and treating, and you can expect good outcome after fixing these fractures, and beware of osteoporosis and redisplacement with these fractures. Thank you very much.
So my question comes in, is it just out of literature that we are not getting the CT scans and MRI in such cases? Because we have, I've personally seen few cases, even epileptics or electric shocks, they present with a bony Bankart kind of a lesion. If we miss it on our initial presentation and we are just coming out doing a GT fixation, we are leaving an unstable shoulder.
If there are other fractures, other injuries,
Because getting a bony Bankart diagnosed on an X-ray is slightly a tricky task.
Yeah, this is only for the greater tuberosity fractures. If you have a dislocation with a GT fracture, you do not need a routine CT to be done. But if there are other injuries, we will
CT
have
and
to
MRI both, I'm asking. Like if there is a frank anterior labral tear along with a GT fracture, and if we are planning to have a GT fixation, is it a good idea to investigate the patient and plan it in a proper elective manner to address all the pathologies together?
labral tear is as a routine is not required to fix in these patients. Some patients may develop more stiffness of the shoulder. So just fixing the GT alone would be sufficient in most cases.
So my question
This is from the literature.
next question to the entire panel is, you have written for the displacement of 3 millimeters, 5 millimeters.
That's for isolated
So
fractures.
in a case of dislocation along with a GT fracture, lot of us have treated our patients conservatively and they behave reasonably well with slight amount of displacement. So what should be the cutoff measure where we should think that we can treat these patients conservatively? Because 3 to 5 millimeter is something which is very small to interpret
Yes,
also.
3 and 5 millimeters have been recommended for isolated GT fractures. For GT fracture dislocations, even anatomically reduced fractures can displace. This is what I had mentioned. And so they need close follow-up for assessing displacement. If it displaces, it's better to be fixed. And actually some authors fix all these fractures, whatever the position they are in after reduction, they fix them. Because of this higher, almost 50% of them displace later.
Thank you. Thank you, Dr.
Thank you.
Srinivas. May I request Dr. Amit Joshi to present a token of appreciation to Dr. Srinivas. Dr. Srinivas, please.